Now we shift to the next speaker. I have the pleasure to present my dear friend, Professor Nizar Albache. Professor Nizar Albache is a consultant at Endocrine and Diabetes Department at Hotel Dieu Hospital de Crissou in France. He's a chairman of the IDF MENA region and former president of the Arab Group for Study of Diabetes and former vice president of the Mediterranean Group for Study of Diabetes. Professor Nizar will speak about the use of new diabetic therapies in developing countries in the year 2019, the pros and cons. تفضل يا نزار.
Thank you, Chairman. Thank you, my friends. Actually, I would start by thanking the organizing committee. In Egypt, we said, once you drink the Nile water, you come back. I would add for that, once you come to ASD meeting, you come back, not only for water, but for the good organization and hospitality. Thank you for all the team of ASD. Actually, I'm not going to tell you where is Aleppo, my city. Of course, you know, this is our hospital, Aleppo University Hospital. But currently, I am working in Hotel Dieu Creusot. You don't know where is the Creusot in France. It's the middle of France. Nobody visits our city, small city. But when you visit Paris, in some way you visit our city because you are going to Eiffel Tower. It was made in our city at the factory. The time was the biggest one in Europe. So this is Le Creusot. There is no disclosure. You know, during 3,500 years of history of diabetes with a lot of progress and medical discovery, we didn't solve the problem of diabetes. We still have a lot of issues. And we have two questions to answer. First one, did we reach our target and stop the progression of diabetes? And second one, did we stop the complication of diabetes and mortality? The answer is no. Why? Because today diabetes still and became more and more epidemic disease and deadly disease in the same time. We know that today we have more than 1 person out of 11 with diabetes worldwide, and 1 of 2 with undiagnosed diabetes, and most importantly, 1 of 6 at birth affected by hyperglycemia. So it's become more and more epidemic disease. More than that, until today, except for UPDS with a particular population, we couldn't decrease CVD and mortality to diabetes. Of course, microvascular diminish is going better with glycemic control. But what about the other complications? We know that mortality is still high with diabetes. 1.8 for all mortality, 2.32 for cardiovascular disease, and 1.25 for cancers. There is more than 230,000 people die from diabetes in the States, and in our worldwide, every 6 seconds a person died with diabetes. In our region, mortality is very high. So we know about that. But going to ask the question, why? Because we are following some guidelines. Guidelines are not adapted, and we are lost sometime within them. This is the IDF guidelines 2012, second-line treatment sulfonylurea. This is also the ADA guidelines, and this is the Egyptian guidelines for 2009. I don't know if you have another one more recent. Second one, history of diabetes at evolution. We know 50% loss of insulin secretion at diagnosis. With insulin resistance, more importantly in our region, an Arab country, we are most insulin resistant than insulin genetic oil sensitivity. So this is important. And also we failed to reach our target. With our traditional approach, we failed to achieve control of diabetes, most importantly about only 25 to 30% worldwide was hemoglobin on target, except for France, I don't know why, 50%. And we don't look for physiopathologic approach for diabetes. When you are treating with metformin or sulfonylurea, we are only dealing with two defects of disease, not the others, as you see here. And more importantly, look for the efficiency of your treatment. When you start with metformin or with sulfonylurea, what's happened? Good efficiency 1 year later. But what about 5 to 6 years? Failure of treatment is very high with this treatment. So don't be surprised to find this result. And to look for beta function, what's happened? Do we preserve it or not? Again, with the same treatment, particularly with sulfonylurea, there is failure of beta cell function gradually and progressively. Now, most importantly, again, there is hypoglycemia and could affect cardiovascular disease, stroke, and so on. This is a recent study mentioned that asymptomatic hypoglycemia, particularly during night, is very important and can affect cardiovascular complication with sulfonylurea. So, only to compare the frequency of hypoglycemia between glimepiride and empagliflozin, 10 times more was sulfonylurea. And did we learn the lessons from CVOTC? No, there is about 30 studies on cardiovascular issue with diabetes. I'm not going to detail all that. I will get some small information to confirm what I'm saying. Hemoglobin. Recently with the credence, there is some improvement with the glyphosine in renal function. Also, cardiovascular deaths and all mortality are decreased with glyphosine. With liraglutide, GLP-1 also are effective on hemoglobin, on weight loss, on all cause of mortality decrease with treatment. So, we can summarize with the new treatment, we have a lot of benefits, particularly with GLP-1, we know about that. Going not only glycemic control, but adding other benefits behind the glycemic control. This is the most importantly, we are not looking only for hemoglobin. We want to try to protect our patients from cardiovascular disease and get less mortality. And you see hemoglobin, insulin secretion, preserve beta cell, less hypoglycemia, and finally have more protection in cardiovascular disease, less mortality than with the traditional approach that we had in our region, particularly in developing countries. So recently, 2 weeks ago, the ASC and ASD come to a new approach and consensus about how to deal with diabetes with cardiovascular risk factors, and they believe we have to apply the new guidelines to reach our targets and to decrease cardiovascular disease and mortality. And this guideline, 2017, is not updated anymore. Second-line treatment, sulfonylurea, have to be discussed before to go with that. And we should be, in some way, try to tailor our treatment according to the patient situation. And this is very important. We already see this for many times. But today, we are going to practical steps, how to try to adapt our treatment according to patient situation and complications. We have the new guidelines 2019 And you see there's 5 subgroups according to the patient situation. Look, first group, if the patient has atherosclerosis cardiovascular disease. In that case, our job, our mission, our duty is to use the new drugs that can protect him from cardiovascular disease, GLP-1, SGLT2, for instance. We cannot continue with this kind of patient to use our traditional treatment and say, okay, I will get hemoglobin on the target. Maybe yes, maybe no. But probably will not protect him from cardiovascular disease. So think about this group, and probably we have a lot of them in our country. Second one, if there is also kidney disease, the same thing, we have to go through SGLT2 with some protection for renal function, as we see in Credence in Barcelona 2 weeks ago. If not possible for any contraindication, we go for GLP-1. And if there is risk of hypoglycemia, this is another reason, maybe most important, to avoid to use any kind of sulfonylurea. Whatever you choose, the risk of hypoglycemia, particularly nocturnal hypoglycemia, which is not diagnosed at all in our countries, can affect cardiovascular disease. Maybe behind the high mortality in a cohort study. So be careful about that. And this, we can use it. If you want to lose weight, and now we have the possibility to get diabetes control, weight loss with GLP-1, and there is once daily, once weekly GLP-1 are effective on treatment of weight loss, and we can use that. And finally, what is really very, very common in our region, the cost. Well, actually, we can go for another option, like TZDs, sometimes sulfonylurea, but be sure there is no complication contraindicate the use of this medication. This was the pros. What about cons? Well, actually, we know there are new drugs. We are not aware about all the side effects. Some of them are known, like SGLT2. We know there is urinary tract infection, acidosis, genital necrosis, risk of low extremity amputation, which is not confirmed, but the Credence recently published. Also with the GLP-1, there is a risk of pancreatitis. So we have always to look for pros and cons. And most importantly, new drugs, you know what are the side effects today. What about the side effect 5, 10 years later? Nobody knows that. So we know we need more studies for a long time, study to get the all. So be aware about that. We need more time for that. But again, the price is a very important issue in our region. And we are dealing with pharmaceutical companies who are huge benefits. Look, for a country in our region like Egypt, the income is very low. And the cost for the medication is very high. If you compare metformin, as 10 trillion pounds, to compare to liraglutide, 1,700, nothing to compare. And if we look what a person with diabetes spends a year for diabetes treatment, it's $176 a year. So it's not like Qatar or Norway or other country. It's limited resources. The question, how they can spend this money on treatment for 1 year is not enough. So there is something missing there. So pharmaceutical company making a lot of profit. Look what's happened. For the first one, this is Johnson & Johnson, around 50, sorry, I don't see that. Yeah, it's about, in 2000, too much benefits, about 50, 60 billion dollars a year, which is very huge. And we can ask them to decrease the prices. But you know, they are not a charitable organization. They are somebody who looking for benefits. They are on stock market. It's not to them to solve this problem. And they are our partner. We are the same boat to try to solve the problem of diabetes. Even this meeting wasn't possible without them. So we are in the same boat to try to fight. Our fight is not against them, with them to try to find a solution. We have, as IDF, as NGOs, to find a solution, not only try to critique pharmaceutical company, but we have our duty to do something in UN. We made a declaration. What about the declaration? Wasn't nothing done, so we have to work. It's not just states, United States or Europe are going to try to get better price for drugs because everything covered by insurance and the state there. The problem is in the developing country. We have to work on that to try to get better prices and make with all drugs affordable for our population. The problem is there. It's our duty to work on that. Not only that, we have to approach our policymaker and tell them, okay, we can now try to spend more money to avoid complication later. But all politicians said, 10 years later, I will be not here as Minister of Health or Director of Health. I want something today to go to TV and make a show. I said, I did that, I did that. 10 years later, I don't care about. So they need immediate result. And also, what we can say and to say, okay, we are fighting against diabetes. We need the new weapons. Can you send your army today to the war with the weapons of 1950? Not possible. We cannot fight diabetes only with the old weapons. We need new tools to achieve our target. Please help us. And lastly, we have to go to UN. We have to need with WHO to try to find a solution for developing country to make the new drugs, which is very costly, more affordable. And this is very important. This is what we can get some money for weapons and seller. They win a lot of money with that. I check my time. So today, with mid-size suit, you cannot dress everybody in your country. It's not possible. You know why? Oh, sorry, this is the other side. Look, mid-size suit is not good for everyone. If you put it, you will look like this one or the other one, so it's not possible. Try to make your size, find your approach, your treatment you need for treatment of diabetes. So, also, the same for the income. With average Egyptian income, you cannot treat all diabetes. You have average for low income, but you are not living in the same way. You are not riding the same car. You are not having the same houses. There is variable average, variable income. Try to find what you can and discuss with your patient and propose what is the best for him according to his own and personal income and possibilities and coverage. Maybe there is private insurance in Egypt, something like that, you can help you. But don't say, okay, I'm Egyptian, low income, I'm going for first step metformin, second one, sulfonylurea. You are not going to do a job. And it's up to you and to your patient to put on the scale what is good, what is possible, what is not possible, what is bad for the patient. It's not like in the state everything is paid. In France, patients don't pay any penny for treatment of diabetes. 100% covered by the state. And this is good, sometimes it's bad. Well, another issue. But for now, in our country, in Egypt, like it has been in Syria, where I have been there practicing for 28 years before the crisis, where I have to leave. So I have the same problem as you today. It's up to me to discuss really take the time to discuss the treatment issue with my patients. And to arrive my conclusion, you know, everything is known. I told you everything about that. But I would say, if it agree with that, maybe the most important and last one, please keep on your mind, cheaper today is more costly tomorrow. Once your complications arrive, you couldn't go back. Maybe if you spend more money, and more than that, once the patient has died, the money you save don't serve for anything. Thank you for listening.
Thank you. Thank you, Professor Nizar, for this elegant and very informative lecture about the new anti-diabetic therapy. And now we'll open the floor for discussion, if anyone have a question. Okay.
Thank you, Dr. Nizar, for this very important talk. You know that in ADA and ASCD, in ADA and SCD guidelines, we always select as a part of cost. I'll tell you something about the market share in Egypt about the oral anti-diabetic agent. You know that a patient running in 76% of their drug is sulfonylurea and metformin. 8% between TZDs and acarbose, and less than 12% in DBP4 inhibitors, and less than 1% is SGL2 inhibitors. We should, in our office, respect patient preference need, and the cost is very important. Thank you for your important talks.
Thank you. I agree with you, but it's time to think about how we can convince patients in our country, in our culture, to spend more money in his health than his meal in the restaurant on the hotel. Sometimes we don't have this culture to put enough money to preserve our health. We ask everybody to do a lot for us, but we're not ready to spend. You have an Egyptian person going to the hotel to pay $300 for a night, but he's not ready to pay $100 for his health. If the state, the government cannot pay, why he can do that? If they have the possibility to do that.
Yeah. Any other question? Okay. مايك المايك يا جماعة في القاعة هنا.
Thank you, Dr. Nizar, Professor Nizar, for such an important lecture. But regarding the cost of management, I think we have to refer to the Diabetic study which was done in the United Kingdom, where they have more economic facilities rather than more than Egypt, for example, and they found that 50% of the patient should for.
Can you prefer louder, please?
Pardon?
شوي.
Regarding the cost of management of diabetes, I think we have to refer to the Diabetic study done in the United Kingdom that was not sponsored by any pharmaceutical company, and was controlled by the Diabetes UK. They found that 50% of the patients of duration of less than 6 years of diabetes could have remission only by diet. So I think diet is the most cheap way of management, and we have to stress that, especially in our communities, referring to such scientific study which proved that 50% of the patient can have remission if they have duration less than 6 years. Thank you.
Yeah, I agree. First step, we agree all. lifestyle modification.
مشكلة وزارة
But you know
الصحة
how
عندنا
it's hard
فيها
to
مرتشين.
change lifestyle modification.
الجماعة اللي بيعملوا الجينيركس
There's a lot of study done.
ثمن البرين.
The most successful one was done in China and then in the States with the new DDP, which is now paid by the insurance. So, but in our country, we have to start with that. Once we fail to change it, we are going to medical treatment. We agree.
Okay. Any other question? Okay. Now we'll close the session and we'll proceed for the next session. Thank you, Dr. Nizar. Thank you.